Hello, my name is Yejin Hong. I'm a medical student in the University of Calgary, and we will discuss today sixth nerve palsy. Ophthalmology and neurology are very closely linked specialties, and one of the diseases that prove this link is the sixth nerve palsy. The eye is a sensory organ responsible for detecting light, and is also physically closely located to the brain itself. The eye is innervated by 4 out of the 12 cranial nerves, the 2nd cranial nerve for detecting light, and 3, 4, and 6 for extraocular movement. The retina, which is the innermost layer of the eye that perceives light and translates the light energy to electrical signals. This also has a neurosensory layer that becomes the optic nerve as it exits the eye from the blind spot. As discussed with the previous slide, the sixth nerve innervates the extraocular muscles of the eyes so that it can move around in the orbit. The sixth nerve specifically innervates the lateral rectus, responsible for abducting the eye. So the left eye moving to the left and right eye moving to the right. The paresis of the sixth nerve, or the weakness of this nerve, can be due to various different processes anywhere along its path from the pons to the orbit. There are diverse etiology that can disrupt sixth nerve function, and it can occur anywhere along the path of the nerve. These locations are categorized largely into 5 components: the nuclear region, vesicular region, subarachnoid region, petrous region, and the intracavernous region. We will cover them one by one. In the nuclear region, the common etiologies include the pontine infarcts, so not enough blood supplying the pons, and there could also be glioma in the pons. Cerebellar tumor, because cerebellum is located fairly close to the pons as well, can press on the nerve too. Microvascular disease can lead to ischemia, and the Wernicke-Korsakoff syndrome, which is a brain disorder due to thiamine deficiency, can lead to this palsy as well. In the vesicular region, tumors, again microvascular disease, and demyelinating disease like multiple sclerosis can be a cause. And in the vesicular, the interesting constellation of symptoms can lead to foveals syndrome, which is a horizontal gaze palsy, ipsilateral cranial nerve 5, 6, 7, 8 palsies. So little weakness with sensation on the face, movement of the face, as well as hearing and balance, and the abduction, of course, of the eye. And lastly, the ipsilateral Horner syndrome, which is a triad of meiosis, ptosis, and anhidrosis on the unilateral affected side. These all combined is called foveal syndrome. Miller-Gobler syndrome can also occur due to an etiology in the vesicular region, and this is a combined ipsilateral cranial nerve 6 and 7 palsies with a contralateral hemiparesis. Continuing with the etiology of sixth nerve palsy, we have the subarachnoid space, and the mainstay of the problem, if palsy is from an issue from this region, is elevated intracranial pressure. And other causes include basilar tumors, basilar artery aneurysm, hemorrhages, inflammation, and meningeal infections. In the petrous space, trauma, like the basal skull fracture, and infection of the petrous bone secondary to otitis media, so the infections spreading from the ear canals can be a problem. And this infection can lead to Grad-Denigos syndrome. This is a combination of one-sided cranial nerve 6 and 7 paresis, ipsilateral Horner syndrome, ipsilateral trigeminal pain, as well as deafness. The syndromes that we've talked about, the foveals, Miller-Gubler, Grad-Denigos, these syndromes are quite interesting, and I invite you to search them up and find out more about them as well. Lastly, in the intracavernous space, the cavernous sinus disease caused by inflammation like the sarcoidosis and Lofgren syndrome, infections including the fungal, especially in immunocompromised patients, and cancers, namely lymphoproliferative like lymphomas, meningioma, and pituitary macroadenomas, can lead to sixth nerve palsy. Symptoms of the sixth nerve palsy that the patient may experience are binocular diplopia, which, as I've said in other cranial nerve palsy videos, is a double vision due to misalignment of both eyes, not because of light diversion within one eye. And that being said, I invite you to watch the other cranial nerve videos as well. Specifically, the sixth nerve palsy would cause horizontal binocular diplopia, where there seems to be two objects placed side by side, no vertical deviations whatsoever, and they may notice an eye turn as well. Some signs that you may observe in patients with sixth nerve palsy is the lateral rectus muscle palsy with the esotropia, and because of the inability to abduct the affected eye fully. Depending on the location of the etiology, you may also notice other neurological deficits if the cranial nerve 6 paresis is not isolated. Other possible diagnosis of a patient that presents with such symptoms and signs may be thyroid eye disease, myasthenia gravis, which is an autoimmune disease. There can be Möbius syndrome, orbital fracture, plus medial rectus entrapment, providing a reason for the inability of the eye to be abducted. And spasm of the near reflex can occur with them as well. The orbital inflammatory pseudotumor, which causes increase in the intracranial pressure, and Duane's retraction syndrome can lead to the inability of the full abduction of the affected eye. So upon seeing this patient with ophthalmic presentations, take a complete and thorough ophthalmic history, do some vitals, and perform a neurologic exam focusing on the cranial nerves. Also observe the extraocular movements. Investigations of the sixth nerve palsy would include fasting blood glucose and the CBC, ANA for autoimmune conditions, cholesterol and lipid panels to see if the arteries are okay, VDRL and the FTA absorption test for syphilis, ESR and the CRP for giant cell arteritis as well for patients over 50 years of age with suspected symptom constellations. Lumbar puncture is done if there's suspicion for infection or subarachnoid hemorrhage, like thunderclap headaches in the morning. Ice pack and anti-acetylcholine receptor antibody test can be done for ruling out myasthenia gravis as well. And imaging and angiography can be done for ophthalmic and intracranial pathologies, as well as aneurysm in the head. The treatment of the sixth nerve palsy, just like other cranial nerve palsies, depends on the etiology. For diplopia, to alleviate it or prevent the progression, you may occlude the eye with the transport clear surgical tape. We may go to muscle surgery of the lateral rectus for long-standing and stable sixth nerve palsies. And for aneurysms, tumors, and trauma that's discovered, this warrants a referral to neurosurgery. And last but not least, definitely treat the underlying medical condition that might be causing or that are causing the sixth nerve palsy. Prognosis of the sixth nerve palsy also depends on the etiology, and complete and near complete recovery can be anticipated with the microvascular palsies. Now here is a comprehensive flowchart of everything we talked about regarding sixth nerve palsy. And this is the reference of the information that we used to compile presentation for the sixth nerve palsy. So thank you for watching this video.